In terms of managing the transition, our key priority during the next 2 transition years is to keep the system safe and operating while we're introducing some critical new funding drivers. And certainly when you look at, while Australia's late to proceed here, and New South Wales amongst the other states is the last cab off the rank on ABF, I think WA and Queensland actually kicked off this year. And of course some places like Victoria and South Australia have had these funding models for a very long time, but all the feedback is that you need to proceed with caution, not overload the model with too many adjustments and refinements and so on. That can happen over time. One of the strong messages in talking with the UK folk when they introduced this approach 5-6 years ago was to proceed with caution as you don't try and solve everything by adding a loading to your price, because you can be trying to load it to push things in this direction and not realise you've created a perverse incentive for things to go in quite another direction, so that we go step by step. So we'll have a cautious and evolving approach to the model. That we will be using transition grants to support those local health districts whose cost of operation is currently above where it would otherwise be if you priced it according to the new transparent funding model. And initially, those local health districts that operate at or below the efficient price will be funded at their current efficient rate. And what happens over time is those, from experience in other systems, is that those that are above the price come down over time, and there is a convergence to the mean. We're also looking over time at how we create incentives and rewards for those that are operating at that lower price. We also have to look seriously when districts or networks are at a lower price, how that lines up against the volumes and so on, and their pattern of services, and whether we've got the funding amounts right as well. And our state pricing structure, we'll adopt the IPA design. We don't want to have one national design and then a different state design. This is complex enough without creating confusion. At the moment, in IPA's draft determination, they're proposing loadings for specialist paediatric hospital services, Indigenous patients, and services provided to patients from outer regional or remote locations. So we'll incorporate those in our design. Previously, when we've had shadow state models, we've had peer hospitals and some other adjustments. We're not going to do that. We will align with the national model. Just to give a flavour of the sort of the spread of funding of districts. I haven't named anybody at this stage because we're still resting with data and quantums and so on, but just it gives you a size. If we convert all our districts into NWAs for acute, admitted and ED blended into one payment and put their budgets together on that basis, that just shows the against no scale, but it just gives you a sense of the spread of districts through to the cheapest to the most expensive against that model. Of course, the first issue is, is the data correct and is the coding right? And in our first year, there'll be a lot to sort out about is the coding right, and also the cost allocation right, because we're also finding that that somebody who might be cheap on the admitted side is more expensive on the ED side, or is more expensive in some of those block-funded services, and that goes to, at the moment, how their costs are apportioned in the cost reporting tools that we have. So there's a lot to sort out, but it's only when you move to actually feeding back, here's your budget if we broke it up on the basis of what you do rather than what you've traditionally received, that you can start to interrogate that and get all those things right. So what does it really mean then in terms of our funding model and a service agreement to move to one that's based on this far more transparent model that is in the first instance next year, 70% of what we do will be ABF'd, and then when mental health and subacute, etc., come on, that percentage will increase. So the larger part of budgets will be based on ABF. for the first time, a district health service receiving its budget will actually be able to see how the funds are built up related to the activity that they're required to deal with, having regard for where they were last year and the sort of growth that they're experiencing. It'll be built up into those various categories: inpatient activity, the ED activity, outpatients, and then each of those areas we've talked about a block grant and other state programs. It will explicitly have, for inpatient and ED, the volumes. At outpatient, because the data's so ropey, all of the states in our conversations are saying that we'll effectively have to block grant that for next year while we try and sort of find the data systems. But it will be a very different looking budget. I was having a conversation with some people from some of our boards, people who have come from outside the health system, and hearing that and sort of saying, well, so what? How is that going to make it different? To try and explain how different this is. This is very different from what I've always called the black box funding model of the historical funding model, which is essentially last year's budget plus or minus adjustments for this year's budget plus enhancements and growth on top. To illustrate that black box model of funding, which is how everybody would have got their budget allocation this year and in every year before that, this is a sample district, and the most important thing to note is that most of the funding, $500 million, just it comes as base budget, which relates to last year escalated for cost increases of salaries and wages going up, etc. And then there's a number of budget enhancements that come through the budget, and that gives you the new black box budget. It's as crude as that in terms of how the budget's received, and then that has to be reinterpreted into what that means in terms of how that funding relates to the job of work that each of those services are meant to do, and the quantum there is entirely, well, it's a product of history interacting with various policy initiatives and budget initiatives over time. And the result is you get that spread that I showed you of those different districts in terms of what they cost for a consistent range of services. What we're moving to, the allocation letter, and this is a mock-up version, is something that's far more explicit and I can't take you through all of this spreadsheet, but the critical things to note, let's see, it does some fancy things here, which I'm not quite sure how this works. So this is this year's budget, which we've taken the budget they received and where they actually are likely to land in terms. And this really is we've mocked this one up, so it isn't any particular district. And where at the moment the district and ourselves are forecasting where it will land. It's actually going to land with a budget deficit, and it is a hypothetical district that's already working on its turnaround plan to get itself back into budget. So then if you take those one from the other, you can see its budget shortfall that it's working on, and they've got a few of our districts in this position. I'm sure some of you can identify with this. For next year, we'll actually be building this up from, there's the acute volumes expressed as DRGs and ED volumes as the various classification systems we have. They'll morph into a single UR volume. We haven't put any particular price in there, though you can do some math, but it's a hypothetical price because we're still waiting on some of the key elements to firm that up. But what we see here is that this district now has budgets in these categories related to the volume of patients there to treat, and that's all weighted for acuity and mix. And it still has its turnaround plan of its budget deficit it has to work on. it's transition grant, which it's on notice that when you construct its budget according to the various categories, it should have this much, but it needs an extra $6 million to bring it up to the level of last year's. So we're keeping it whole going into next year's, but they're on notice that this is an issue that needs to be addressed. It can be coding, it can be some structural inefficiencies that need solutions that involve some capital, or it can be, and quite often goes to models of care, lengths of stay challenges, availability of services in the community that patients can be discharged to. But it starts to put all our health services on notice as to that discrepancy. And this is and it's broken up by these various categories, and then behind this can be a much more comprehensive unpacking of where the money's going and what services it's buying. This will lead overall to very different conversation, both at the local service level, the local board level, as well as between health services and the ministry, and then in turn between the ministry and Treasury about what funding we need to run the health system, where it's being applied, and a very different conversation.